All right. Good morning, good afternoon, good evening, everybody out there. Welcome to the August 30th CMR Journal Club. We have two very exciting papers that we're going to discuss today on the topic of CMR at 7T, so high field cardiac MR. These papers are going to be presented by Dr. Maxim and Dr. Sebastian Schmitter, and we're just going to jump right into it. So the first paper that we're looking at will be presented by Dr. Terekov, and this paper is about running routine cardiac MRI at 7T. It's a pilot study on the consecutive 84 examinations of patients. So I'm going to let Maxim take it away. You can go ahead and share your screen and we can take a look at the paper.
Can I share my screen?
You should be able to share now.
Okay. Sorry. Can you see my screen?
It says you started. Yep, perfect. Here we are.
Okay. Thank you very much. So, dear ladies and gentlemen, thank you very much. And thank you, organizers, for your invitation. I would like to present our paper, which Nicole already presented the title, and I will jump directly to the subject. So basically, we scanned quite a lot of volunteers on establishment of the 7 Tesla MRI in our center, in the comprehensive center of the heart for the heart failure in Würzburg. And among these volunteers was 32 males and about 40 females. And in total, it was 72 unique volunteers and was 84 examinations because some volunteers came twice. And with this paper, we shared the result of summarizing our findings during the studies. We checked a number of correlations we wanted to have a look and find out. And the main goal was to understand, as it comes from the topic, if 7 Tesla MRI already feasible to be used for the clinical routine and how far we are from this final goal. So, as maybe most of you know, that 7 Tesla MRI is quite challenging in terms of the hurdles which one need to overcome to scan hearts, and only few groups worldwide nowadays capable to make the cardiac 7 Tesla MRI. And main challenges is B1 homogeneity, or rather B1 inhomogeneity. There is no body coil in 7 Tesla scanner, so you need to use the dedicated coils, and there are not so many manufacturers who produced such a coils. So in this work, we used the coil we got with the scanner. This is a coil from MRI tools from Berlin, and this is single TX coil. So our goal was to find out how suitable this standard coil for the scan of the heart. And second feature of our scanner that it is a scanner supplied, our Theresa scanner supplied with a third order shims system. So in total we have 12 shims. Full set of the second order and partial set of the third order shims. So we wanted also to test how good they performs for the cardiac. So regarding volunteers, as I said, there was 84 examinations and 40 female and 32 male. The scan protocol we take over from 3 Tesla, but it was necessary, of course, to modify it for the 7 Tesla to reduce as much as possible echo time, so to minimize the artifacts coming from B0. Then we also, of course, adjusted Grappa factor, and we found out that this coil we have is capable to scan with an acceleration factor 3. Then we, of course, optimized the protocol itself, how many slides we want to make, and one of additional challenges of 7 Tesla again, many of you probably know, is that it's quite difficult to use ECG triggering on 7 Tesla because magnetohydrodynamic effect is quite strong, and therefore the scanner additionally supplied with a acoustic triggering system also from the MRI tools. So in this study, we additionally compared how efficient can be triggering with the acoustic system and with ECG system. We used both and we compared both of them. Overall, the quality of images we estimated, it was estimated by the experienced radiologist and cardiologist who actively used 3 Tesla scanner and quite experienced also in high field MRI. And they estimated the quality of images by different parameters, so, scored from 1 to 4. 4 was the worst, 1 was the best quality, and 4 parameters was taken, and we sum them up and make a total index of the estimation. Additionally, they did the functional analysis, so that we analyzed in MediSuite all images, and physicians extracted the same cardiac function parameter from cine images that they used to do in clinical routine, so stroke volume, ejection fraction, and so on. That is all summarized in the table in the paper. So I come to the results. So first we had a look on the shim system. This is one of the new stuff that we have also a paper on this subject. And we had a look how the image quality correlates with the shimming. And we did it retrospectively. We checked how the quality of images correlate with the usage of shim and how much we used shims in principle. Here one can see on this figure, probably I will try to zoom it, how the first order, second order, and third order shims are used. And one can see that, for example, that cube shim is used to the extreme. So the current demand there is in principle higher than 100%. This we also checked with additionally there are ICMR abstracts on this topic. Later on we find out, but the conclusion about the shimming system that even third order shims are not fully sufficient to suppress all B0 artifacts, especially in the posterior and lateral wall. Then we checked, as I said, the diagnostic quality of the images. This our cardiologist and radiologist did. Overall, you can have a look that one can see the problem at the posterior and lateral wall. It is where the B0 is the most problematic region for B0 shimming, because this is region of interface between lungs and tissue, so strong susceptibility artifacts occurs there, and therefore for shimming system it's very difficult to suppress it completely. And also for the coil, it's the most difficult region because it's the most remote region from the coil, and averagely B1 drops by the factor 3 in comparison to posterior wall in this region. So these 2 factors makes it most problematic to visualize this region. And if one comes to the summary of the quality, on this map you can see that the dark color means highest quality of image, and yellow color means worst one. And you can easily see that both noise and image quality and artifacts are the best in the posterior wall and in the so in the segments 1 and 2 by the AHA classification, and the posterior and lateral wall are most problematic. So this is quite explainable if one think about both B0 and B1 homogeneities. We also analyzed how the position of the coil correlates with the image quality, because on the scout in the initial scout, one can easily see the coil with a short echo time at 7 Tesla. You can see the contours of the coil, and one can retrospectively check what is the relation between the image quality and how the coil was positioned with respect to the heart. And we didn't find a significant correlation in left ventricle, but I think there was some correlation with regard to right ventricle. I'm not sure if one can be conclusive about this, because nowadays we use already a different coil. We switch to the new product coil, which has a PTX capability. In the moment, we use it only in single TX compatibility mode, but we are on the way to use it in PTX. But with regard to this MRI2 coils, we found that in principle there is no strong correlation between the position of the coil and image quality. The interesting things was with regard to the flip angle, because we needed to adjust it on directly or for each specific subject. And there was quite a big variety of the flip angles, nominal flip angles we used. It varied from 12 degree to 40 degree, depending on the subject we use. But this reflects just the fact that the B1 homogeneity depends strongly on the thorax shape, or on the body mass index, if it is male and female, and so on. So we have quite a big variety of this, and in principle, this is one of the factors which we need to take into account always. And additional factor is that each subject has a different heartbeat rate, and specific absorption rate depends for the cardiac imaging also on the heartbeat rate. Therefore, we had to adjust flip angle to the maximum SAR which scanner allows us. So I'm coming to the conclusion. In principle, one can say that we could say that based on these 84 examinations and in 70 unique subjects, we can say that even with using the single TX coil, we are on a good way to the possibility to use it to use both scanner and coil for the clinical routine scans when we speak about cine imaging list and functional cine, because the results we get in terms of the different functional parameters like stroke volume, ejection fraction, and so on, they correlate very well and fits very well with the 3 Tesla results, and there were no significant discrepancies found. So in this context, the functional cine can be used in 7 Tesla as efficient as in 3 Tesla. And just in the conclusion, some words about the acceptance of the subjects. Mostly we didn't find any difference with or physicians didn't find any difference with the 3 Tesla in terms of acceptance. Was only 2 subjects who experienced claustrophobia. The 7 Tesla scan has a bore which is a bit longer than 3 Tesla, and therefore people there may experience it a bit more claustrophobia. There was not much nausea or vertigo. Only some people claim that they have experienced vertigo and kind of nausea. And we didn't find any sensation that people claim that they have a heating from the coil. So no SAR access obviously was found. So we were quite conservative in this respect, but anyway, this is also good to know about the coil and about the scanner. So with this, I would like to thank you for your attention and welcome your questions, of course.
Great. Thank you so much, Dr. Terekov. So we have a couple of minutes for brief questions. So if you have a question, you can either type it into the chat box, you can unmute yourself, you could raise your hand, whatever is the easiest for you. Maybe I'll get started. So, based on these experiences that you've had with healthy subjects, have you moved on to scanning patients?
Yes, we scanned probably 5 or 6 patients afterwards with infarction. The problem with patients, of course, that we have a quite we had, especially at that time, quite conservative exclusion criteria. There shouldn't be any implants. Even dental implants was not allowed because what was our first ethic approval, and this ethic approval was quite conservative. But we had scanned 5 or 6 patients at least. Afterwards, we had no difference in terms of scan protocol with volunteers, and we had no difference in terms of the discomfort or any problems with the heating and nausea and so on. So practically with patients we had the same experience as with volunteers. The only difference, as I said, that with patients one need to be more careful because many patients has different kind of implants. They are typically older, and the older persons, they're more difficult to find someone without absolutely without any implants. But in the moment we try to relax our exclusion criteria, and there will be less problems with finding also patients.
Got it. All right, I'm going to let Sebastian ask his question.
Yes, thank you very much, Maxim, for the presentation. I have just one quick question, which is actually then afterwards related to my own talk. You also looked at the delta B0 values. How much was it in the end when you do third order shimming? How much variation do you have actually on the Terra then in the end across the heart, roughly?
Yeah, if you remember, we even discussed this once with you. It was typically it is about 100 Hertz in the septum and up to 400 Hertz in the posterior wall. And so one can easily see that the non-compensated high order variations like second order and even third order, because we analyzed it in terms of decomposing residual B0 in spherical harmonics.
Because then I have it correctly in my mind, because I mean, in our case, we do not compensate actually we do not shim at all. And because we have issues with that. And so, okay, good. This was actually all I wanted to know. Thanks.
Yeah. So from 100 Hertz to 400 Hertz, it's a variation.
And very quickly, we have a question in the chat, which is, if you tried both SSFP and GRE Cines, and if so, which performs better at 70?
We couldn't use SFP. There are 2 problems with that. First, the dark bending, and second, it's too demanding in terms of SAR because TR is short, and you just cannot use SFP at 7 Tesla so easily as GE. So we use only GE.
All right. Thank you so much. We are now going to move on to our next speaker, Dr. Schmitter. And he's going to be presenting his paper on motion-compensated fat water imaging for 3D cardiac MRI at ultra-high fields. So Dr. Schmitter, you can go ahead and share your paper, and we will, we're ready for our next exploration into 7T CMR.
Okay, thank you very much. Can you see my screen right now?
Yep, perfect.
Yes. Thank you very much for inviting me or to present our paper. So this paper is mainly written by, the main conductance is by Sebastian Dietrich. He was a PhD student in my group. He just finished. And we did this in Berlin together, so from PTB, together with Charité, Jeanette, Schulz-Menger, on our local 70 scanner. I should say in advance, our 70 scanner is different from what Maxim was showing. He has a Terra system. We still have the old machine. And so some of the things are actually related to the machine. Okay, then let's start. So our long-term goal is basically we want to do fatty infiltration identify fatty infiltration of the myocardium. This is our very long-term goal. It's very long-term goal. So, until now, so we try to establish, well, a routine scan to go towards there. So we want to do fat water imaging at 7 Tesla in the heart, and this is a little bit challenging, and I want to show you actually the different pieces that fit together. So why do we do this? The benefit is here, it's not only SNR. And when you look at the benefiting techniques of 7 Tesla, it's often those ones that actually benefit twice. So they have a double benefit, like functional MRI, they have bold effect plus SNR. And here it's the same. We have SNR plus the spectral resolution. And this is really a feasibility study. So what I would like to show you here today is the different steps that are actually needed to go there. And it's actually the first time that a multi-echo cardiac and respiration resolved acquisition has been applied at 7 Tesla in the body. And so there are different pieces. The first one, and Maxim has already pointed that out, B1 heterogeneity is a huge problem, and we faced this using parallel transmission techniques. Then ECG is a huge problem, also already mentioned. And then like a standard navigator, let's say a pencil beam navigator or crosspair navigator does not perform well at 7 Tesla due to B1 problems. So we use self-navigation in this case. And then also delta B0 is a huge problem, as Maxim was already saying. So this is really a feasibility study. We don't have any patient scans. We investigate 11 subjects and try to establish this technique and look at the different challenges that we're facing. We used a non-Cartesian acquisition, RPE trajectory radio phase encoded acquisition. So in Z direction, we have the readout, and then within the 2 phase encoding directions, we scan the K-space in radially. Why did we use this sequence? Answer is very simple because we just had it. So Tobias and Christoph, who used to work in London, they worked quite a lot with it, and we just had it here then, and then applied it at 7 Tesla. We have 2 different basically acquisitions, or the acquisition is only 1, but 2 reconstructions. So first we had a particular look at the B0 maps, and we reconstructed non-respiration resolved B0 maps, respiration resolved B0 maps, and then afterwards we applied also motion compensation on the respiration resolved maps, and then we had a single motion compensated maps. And we did the same for the fed water images. So we had non-respiratory and non-cardiac resolved fed water images. Then we had actually binned the cardiac phases into 5 different cardiac phases. So we had non-respiratory and cardiac resolved images, and then motion compensated and cardiac resolved maps. So this is, of course, then the best images you will see later. And then from the, so we used the standard reconstruction method that has been published already. And from the method, which is different now to the previous talk, is we applied this all in PTX mode. So we had also MRI tools coil, but in this case, we had 8 transmit channels, and we were able to do B1 shimming, so static PTX, and 32 receive channels. And then what should be mentioned, so we have 11 subjects scanned with a quite wide range of the BMI. And as I already mentioned earlier, we did not do B0 shimming. This is due to the system itself. So the PTX system is a prototype system, and we had really huge problems with B0. So in the end, we gave up, and we just used the default tune-up shim, and that actually did work better than shimming in the end. But this is also related to our system. We had like a fast B1 mapping scan that we actually published 2 years before. Yes, and for the acquisition, we had 2 kinds of acquisition. The first one was 1.4 millimeter isotropic. So it's a triple echo, 3 gradient echo with sequence with 3 echoes. In 10 minutes acquired, and then we also had looked at a 1.1 millimeter resolution image, and this was acquired in 11 minutes. We had to do a couple of things, but I want to skip this and rather jump right away into the results. So what you see here right now is in this image, so the 3D acquisition, GLE acquisition of the localizer or of the acquisition without shimming. So in this case, this coil is, if we do not apply any additional phases, actually it's meant to be a cardiac and aortic coil. It should provide decent signal in the heart and also in the aorta. But we actually experience, it depends a lot on the subject shape, and so for example here you see like a hole in the heart here on this in this subject, and after applying the PTX method, then we can actually get rid of it, and so that's worked very well. Then in the next step, we were actually looking at delta B0. That was important to us because we were not so much worried about let me just jump to the next figure. We were not so much worried about delta B0 per se. It was more the changes of delta B0 during the respiratory cycle, because delta B0 is part of the reconstruction framework. And if delta B0 kind of changes too much, we were afraid that actually the entire pipeline will break down. What you see here now is differences of the static magnetic field for the non-respiration resolved scan, and then for 4 different respiratory states. And what we can see here, and these are line plots here along the horizontal and vertical axis, we can see actually that, well, we do have a couple hundred hertz here of variations across the heart, which is quite remarkable. But also during respiration, actually it changes by a couple, locally by a couple of tens hertz or up to 100 hertz. We looked at this in more details for all the subjects. And what we found out is basically, it's kind of that the distribution of delta B0 kind of stays constant across the heart during respiration, but it's rather that we have a shift. So the shape of the curve kind of stays the same or is unchanged. But we have like about 10 to 20 hertz shift, which is pretty good, because when you compare it to the range of the fat water frequency, about a little bit more than 1000 hertz, then this is, let's say, more or less negligible. We also looked at this in more detail when we actually applied motion compensation for the different delta B0 maps. And so then you can directly compare to the exhale, the inhale map to the exhale. So on average, we had a variation of 10 to 20 hertz. I think it was like 14 hertz. But locally, we went up to like 60 hertz or 70 hertz. But again, so delta B0, change of delta B0 across the cardiac cycle, across the respiratory cycle seems to be okay. And then here, I would like to show you the results of the fat and the water reconstruction. And these are the 3 different types of reconstructions. The first one is non-cardiac bind and non-respiration resolved. We see 2 things. The first one is, well, it's a little bit blurry, the image, the water image here. And for the fat image, which is kind of interesting, we see some fat signal basically in the aorta. This is not cardiac resolved, so that means we have also contributions from the systole. And during systole, the blood is quite fast, so it accumulates due to the M1 and also M2 magnetic moment. It accumulates some additional phase just due to the velocity of the blood. And this gives us here some error in the signal. If you now cardiac bin them, so we did 5 different bins, cardiac bins across the cardiac cycle. And we picked here now for demonstration purposes the diastole. Then you can see actually that this artifact is reduced, which kind of supports our hypothesis. In the third reconstruction, and here the difference between those 2 is only that we took different delta B0 maps. So this is non-respiration resolved delta B0, and this one is motion compensated. And we do not see much difference between those ones, which is good news, which makes our life easier. So we can take this one here. But what we see is actually that we see sharper images, and also we have higher fat signal. This is also we looked also at this in these line plots here. And then let me come to one other aspect that Maxim has already mentioned. So the ECG at 7 Tesla is a huge problem. And so they are really varying reports how efficient actually it is and how many errors we have. In this study, we really took very much care of placing the ECG leads and replacing them. And when it looked bad, we didn't even start with the study. In the end, we were able in 10 out of 11 subjects to get a trigger efficiency about 99%. So that means 99% of the triggers were correct. But still, we sometimes have these issues which is shown here, that kind of the ECG just drops out. This is still a problem for us. Then in one of the subjects, and this is in the supplementary material, we had a trigger efficiency of 80% only. And there we saw the typical problem that in some cases, the trigger switches from the R wave to the T wave and back and forth. So this is due to the magnetohydrodynamic effect, so that the T wave is so strong. And the trigger really does not know which one is the correct one. And this is a substantial problem at 7 Tesla. And it even becomes stronger when you go to even more higher fields. And so what we were looking then is actually, okay, how much does it affect the trigger efficiency? How much does it actually affect our image sharpness? And so here we artificially reduce the trigger efficiency. And what we could actually see is, for example, the identification of the coronary arteries becomes much, much less visible. So it does have actually a substantial effect. So the trigger is very important. Nevertheless, I think having in 10 out of 11 subjects such a high trigger efficiency, this is really important to us, and it gives us some hope that in the future we will be able to really get good results. These are the final results here for the water and the fat fraction images. So we obtained these shown here in 2 different subjects and different orientations. So since this is a 3D data set. And also what we looked at then is also a little bit higher resolution. We were pushing towards 1.1 millimeter isotropic resolution. Of course, identification, so spatial resolution is higher, so we could identify the coronaries much better, for example. Okay, with this, I would like to just, for the last 2 minutes or 1 minute, just go into the discussion and just say the limitations. So it works, this is good, and you have seen actually the individual problems that we have. So we have to face B1, we have to face B0, we have to face the ECG and so on. But it seems that we can handle that. The problem is there are some more limitations which I want to actually mention. So this quantification is of course impacted by T1 and T2. We have seen this also in phantom scans. So much more work has to be done there. The second one is actually, it is overall extremely complex. So the B1 shimming, so the PTX system, it takes us quite a while to actually run it, and also to calculate the B0, B1 shim and so on. So it takes us at least 10 minutes or more. And then the ECG, of course, I mentioned that is a problem. It would be good for the future to have better solutions for that. And then, as you see, the contrast is not very well. It's not very good. And at lower fields, you often use T2 preparation. We cannot use this here because of power limitations, which is a strong problem. And also, we pushed it to 1.1 millimeter resolution. You could say, okay, at 3T, I can do that as well. And well, you're right. So we didn't push it further, but in principle, we have sufficient SNR to do it. So with this, I think I'm done. Thank you very much for listening to me, and I'm happy to answer questions.
Great, thank you, Dr. Schmidt. So again, if anyone has any questions, you can drop them in the chat, or raise your hand, or just go ahead and shout out your questions. Maybe again, I'll start. So actually, I was noticing in your fat images or fat fraction maps, what values were you getting in the myocardium? And are those maybe a little high, like you were saying, due to T1 and T2 star effects?
Yeah, I can. The first question I cannot really answer at this point here, because I don't have the values at hand. I would have to look at it. What I know is that we actually did quantify it very well in the phantom, because we also noticed it, and in the phantom we also saw values that were changing by like 20% off. So and this is the problem. We know this, and we have to do something about it. So probably we also have to include more echoes, and so there's really much more work to be done. Yeah, that's basically it. Yeah.
Right. Do we have any other questions from our audience? Okay, maybe I'll ask very briefly one more question. So you used this RPE, radial phase encoding scheme, because you had it. And now, since you've done the study, would you collect data differently? Is there something that you think it would work better than this, or are you going to stick with this now because it's completely sufficient?
I think it's there are two different options. You could do radial stack of stars. If I would have to choose, I would do radial stack of stars because it's easier in terms of using slab selective excitations. So I would maybe go that direction, but to be honest, we were happy to have a sequence at all that we could start with because we had so many other problems. And if you have already a sequence that you can start with, that was already quite helpful to us. So give you an honest answer. If I had to choose, if I don't have anything right up front, I would, due to the slab selective excitation, I would probably go towards stack of stars.
Got it. Awesome. And we have a question from the chat. Is optical PPU as an alternative to ECG triggering possible at 7T?
Yes, but to my experience, it's actually the jitter is much higher compared to the ECG. So we also notice it's sometimes unreliable. And then there's also the problem that some of the sequence only work prospective. So this one here not, but this, since we do everything on our own, we actually do not use it much. It's mainly because of the jitter. We also use the acoustic one that Maxim has actually spoken about. But we see the problem is with the acoustic one, you don't really know if the trigger is wrong because it's like a binary signal, and it's always difficult to see if there's an error. So we actually stick to the ECG and really pay attention on gluing or putting the electrodes very correctly on the skin, and taking a lot of time, and we have in the meantime also some experience.
All right. If there are no more questions, we're going to wrap it up, and I'm going to ask Dr. Schmidt to stop sharing his screen. And I'm going to try to share my screen, which hopefully I can. All right, so I'm just going to use this as, hopefully you can see this, just as a small ad for the SCMR co-provided workshop right before the ISMRM. This year is on low field and high field CMR. So if you're interested in high field CMR and 7T or in low field CMR, then this is the place for you. We're calling this kind of unconventional field strength CMR. So anything that's not 1.5 or 3T, this is what we're going to be highlighting here. And so the program that we put together is actually pretty awesome. It's a day and a half that's like packed full of low field and high field info. And if you are working on these field strengths and you want to submit an abstract, you can submit them through the SCMR website. So it's basically the same as an SCMR abstract. You would just select the co-provided workshop for your abstract. The deadline is September 12th. If you submit to this workshop, we'll also be potentially sharing with the SCMR. So it's not like one or the other. You can kind of submit to everything all together, and we'll be sorting through to see which abstracts fit here and which might fit better at the main meeting. So don't be worried about submitting it here and then not submitting it to the SCMR. We'll be making sure that things are in the right places when you do your submissions. So I dropped the link to the program in the chat if you're interested. And then a final plug. So of course, we're going to be back next month with our CMR Journal Club. Mathias is going to host this one. It's on September 27th. So this is a week shifted from what it usually is because we wanted to avoid the ESMRMB, which is the week afterwards. So the topic of our next journal club is going to be oxygenation sensitive CMR, to see what's new in that field. So make sure you join us, and you've all signed up, so you will be getting the information. Tell all your friends who are interested in CMR and oxygenation sensitive CMR, and hopefully we will see you then. So have a good couple of weeks until then, and thanks again to our presenters.